Defensive medicine is a derogatory expression used in medicine meant to describe a certain style of practice that emphasizes the focus not on the patient's well being but the clinician's interests. It involves excessively covering all the possible scenarios imaginable when looking for a diagnosis or preventing undesired outcomes. That means more testing at the cost of distress to the patient, increased time that the patient needs to spend engaged with the healthcare systems, and exploding healthcare costs to the society. This style of practice is considered to be a problem of the healthcare provider, while healthcare providers who have been sued for trivial or completely made up problems in the way they managed a certain clinical situation are furious when someone tells them that somehow their overly cautious approach is a problem. It is like telling a victim of a crime that is ridiculous to get a gun license, buy a gun, start target practicing in order to defend himself or herself in the future if there will ever be another attempt to victimize them. So, where is the demarcation line between safe medicine and defensive medicine? It is a classic psoriasis paradox. When does a pinch of sand become a heap of sand? If you have a pinch of sand, let's say a few hundreds of grains of sand, and you start adding 1 grain of sand at a time, when does a pinch change into a heap? The same with defensive medicine. When does prudent medicine that minimizes the risk of a misdiagnosis and the likelihood of developing complications from the illness or from its treatment, like anybody would prefer when it comes to their own health, become the scorned defensive medicine, a style of practice that is centered on the concern for one's own vulnerability to get sued, putting the interest of the patient on the second position on your value scale. Some might argue that defensive medicine includes prudent medicine, or it is prudent medicine and beyond. Defensive medicine, though, comes at a cost, which I will describe in more detail later. Medical practice is like many human activities. It has a well defined quality parameters. If you do a sloppy, fast job, the outcome will not meet the minimum standards of quality and the product or service will be unusable. But as you try to improve the quality of your work, the input into that task, time, and money starts rising. At first slow, then exponentially, the closer you get to perfection. And there is, theoretically, a point beyond which diminishing returns become a major limiting factor. For example, when rising the quality of your products or service from 60% to 75%, the additional cost is very small. To bring the quality up from 75 to 85%, a smaller increase, the cost starts though rising. From 85% to 90%, even a smaller jump than before, the cost comes close to the maximum the customer is willing to pay. And above 90%, even a little bit, it will be like losing money each time you deliver the product or service because it costs more to provide it than what you can get for it. So, no longer a viable economic activity. In summary, where is the boundary between defensive and prudent medical practice style is almost impossible to establish with accuracy. But that does not mean that the extremes are indistinguishable from each other. A sloppy, careless medical service is easy to spot. A defensive medicine style of practice, a little more difficult, but still not impossible. In psychiatry, when I started practicing 25 years ago, the standard was that you need 3 1 hour appointments with the patient before you decide what diagnosis is suitable for a certain clinical case. Nowadays, if you cannot make a diagnosis within 45 minutes, you are out of luck. The insurance will not pay you more than one initial evaluation, and an experienced clinician can be efficient enough to do it in 45 to 60 minutes. So the beginners who need more time than they, in a way, uh, pay the penalty for their slowness by getting reimbursed less per unit of time if they cannot reach a diagnostic conclusion within 60 minutes. Then there is, of course, the issue that the insurance prefers to ignore and stubbornly refuses to discuss. The paperwork without which no insurance payment will happen take time, rarely less than 20% of the time you need for the evaluation itself, unless you master the art of composing a properly structured note while you speak with the patient. This skill comes in time, since it is difficult to simultaneously think about the questions you need to ask, to listen to the patient's answers, and to write the relevant information in a systematic note without which you cannot justify to the insurance the billed service, and prove as well to whomever wants to appraise your work that all the professional standards in providing that service were met. This is not a trivial skill, especially that the information from the patient almost never comes in an orderly, predictable way necessary to fill a structured, coherent, easy to follow progress note. To do this intellectual, strenuous effort and be able to extract value out of your hard earned expertise and do it in a way that does not create legal vulnerabilities remains something that only considerable years of practice can acquire. Always imagine that a bunch of litigation lawyers whose livelihood depends on proving you did something wrong will use their hard earned expertise to find holes in medical reasoning as reflected in the progress note. Given the harshest legal environment on the planet in which clinicians in this country have to practice, I cannot say that defensive medicine is worthy of disdain or scorn. But aside from the liability concerns, which is a force that pushes clinicians towards defensive medicine, there is another force that pushes them away from this style of practice, a force even more effective than the public shaming of its practitioners, and that is the financial pressure. The more you engage in defensive medicine, the less you get paid per unit of time, since the investment of time is not only on the side of the patient, but also on the side of the clinician, and maybe of the codified services in the CPT manual have time limits. So you are not going to get paid more if you provide a certain service in 15 minutes or in 75 minutes. So the end result of the decision how to practice your profession has to be at a balancing point between these opposite forces: the need to maximize your own income, which pushes clinicians to work fast, and the need to minimize the risk for medical litigation, the risk of harming the patients, forces clinicians to spend longer time with the patient to be able to think of the complexity of each situation and the ramifications of all the clinical decisions a clinician will have to make. Very similar with how a chess player has to imagine several moves down the road in order to maximize his chances of winning the game.